Mr. Choudhary, Mission Director NHM Jammu and Kashmir, to give his presentation. Thank you, sir.
Thank you. Thank you so much, Garimaji, and thank you so much, Raviji and the team at Elets for organizing this wonderful event. I've been a part of some earlier events by Elets, and it's always been a pleasure interacting with such brilliant minds all around. So thank you so much for coming over and taking time out to listen to me. I'm Yasin Choudhary. I am an IAS officer from the 2015 batch of Jammu and Kashmir cadre, and I'm currently MD NHM and ABDM, Ayushman Bharat Digital Mission in J&K. Now, I am here to talk about what we can possibly say is the single biggest intervention in the health sector planned for this decade. If there's something that COVID has taught us, I mean, I personally has been MD NHM for the last 2 years. I had battled the first wave as a district magistrate and subsequently as MD NHM for the whole UT of J&K, and I realized that what was of essence was scale. It was how quickly you managed to, test as many people as possible, how quickly and efficiently you managed to track as many people as possible, how quickly you managed to raise the capacity of your infrastructure and are able to provide services as quickly as possible. And if there's one thing that will enable scale and efficiency, it's technology. We have had many, bursts and spurts of some technological advancement within the health sector at different points of time. NHMIS is in today's time a very basic thing which you would want to see in every hospital. But how does it all come together? I mean, I'm sure that all of you, or at least your parents or grandparents in your households, would still be managing a bulky, folder or at least a, bag full of old medical records from all along, some various hospitals, various consultants and specialists. How long are we going to do that? And is it all going to lead up to something? So when we talk about digital health, we basically need to have an end-to-end system which will enable us to do away with that buckloads of paperwork in the name of medical records to begin with, which as a system would ensure, not just confidentiality of patient records, but also, portability of the same. And of course, user access, user consent, privacy being the keystone here. And further on, a system which is so robust that it should be applicable from, say, a remote district located on the LOC in J&K to, an advanced tertiary care hospital in Kerala. And lastly, it should be, and this is something that I personally, lay a great deal of emphasis upon, and that's the idea laid forth by WHO in this whole year, is that of universal health coverage, or UHC. A system which enables digitization or the provision for the same, or has a capacity to accommodate, anybody in our society, be it, that poor tribal on the LOC in J&K, or maybe say a rich businessman in Kerala. Both of them should have the exact same equitable access to this digital platform and should have the exact same nature of medical records. I mean, I, as an IS officer, really don't want to see a person claiming that just because I went to Medanta, so my digital records are more perfect than a poor person who's never seen a private hospital. Even if he is going to a government hospital, a government PHC, no matter how ramshackle is it, there must be some provision of initiating his or her digital health record. And this, how are we going to do this? I mean, in a country of billions, this is easier said than done, but we do have a blueprint, and we've already started doing a lot of work on that front. So basically, the union budget announcement was that major, fillip to ABDM. It was erstwhile known as NDHM, and a lot of it was floating around in the air without, any tangible thing on the ground. And we were getting a lot of brickbats. Is it ever going to take off? Did they ended up, planning it way too ambitiously? And no, this is not going to happen. There are too many elements, way too many stakeholders, too fractured sectoral landscape to worry about. So how do we go about it? So as I said, a citizen-centric national health ecosystem. We bring together technology and healthcare, and this might sound like the point where one of those, corporate pitches start beginning with a lot of jargon and all. But let me tell you, this has been thought through by some of the most ambitious, most successful technocrats in the country, and one of them you're going to have the privilege of hearing today itself, later in the day, Shri R.S. Sharma sir, doyen of the Indian Administrative Services, and hands down possibly the most successful technocrat in the country, not a bureaucrat, a technocrat. The person behind Aadhaar, on that's UID, on which is hands down possibly the largest scaled ID in the whole world, and the person also behind ABPMJ, Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, and now ABDM. And further led by a team of brilliant officers like Dr. Praveen Gedam and Dr. Vipul Agarwal, who had been building up this blueprint all along. So when we talk about the backbone, creating a digital backbone to the health sector, we obviously need to talk about an integrated model. A model which would work, say, for, as I said, a ramshackle PHC in a remote rural periphery, as well as, say, a leading institution like AIIMS. And it will also bridge the gap within the existing stakeholders through a digital highway. And this is where NHA built something called, which this is terming the Interoperable Platform. So imagine, like we have a country, we're a huge nation with lakhs of health institutions, millions of pharmacies, thousands of labs and whatnot. And how does it all come together to ensure standardization of that health record? So that IO, the interoperable platform that has been built by NHA, is a sort of digital highway which enables, and this is actually very unbelievable, a plug-and-play system. Simply put, if you are a, say, private hospital in Noida, and you have a local HMIS, and you want to be ABDM compliant so that the patients you're treating manage to get digitized health records which they can use, say if they go for a referral to AIIMS or Medanta or anywhere. You don't need to do anything. Your existing HMIS will be as useful in for us as, say, something that we built ourselves. It's the ingenuity of the IT team at NHA, where they've devised such open adaptability, such open compatibility prospects and possibilities that it's actually happening very smoothly. For instance, the largest tertiary care government hospital in J&K, namely the Sher-e-Kashmir Institute of Medical Sciences, has a health record which has more than 60 lakh entries, and all not deduplicated. And we never really thought we'll be able to do anything with that data, but it just took us like 3 weeks to sort it all out, and all those 60 lakh entries are attributed to unique individuals, IDs which are Aadhaar linked and obviously verifiable, and which can be further built upon. So any of these individuals, if he walks into SKIMS again, this particular hospital again, he can actually retrieve any sort of OPD or IPD consultation record which he might have generated say a decade ago or so. So what do we intend to solve here? So obviously, as talked about my predecessor speakers, there's always been a disconnect when we're talking about health systems in a country like India, a large one at that. There's an issue of too many service providers, too many service consumers. How do we bring them together? So availability, checking the availability of medical resources, services, products, booking the same, ordering those services, and finally availing them. And of course, for healthcare providers, an access and view to the patient's health history. And this is where I come in. I am very proud of coining an adage. So they say data is the new oil. I say health data is the new gold. No other sort of data regarding a person or an organization is as valuable as his or her health records. Do you agree with me or not? I mean, I'm okay with, say, like my shopping history being, I mean, I'm not okay with that also, but I'd be like more worried about somebody finding out that I have piles or hemorrhoids or something like that. So that's of great essence. And this is what we have to realize as government, And whatever I'm saying as a government, I'm not here to sell you anything. I'm not here to pitch a product. I'm not here to, talk as a successful entrepreneur who's made a huge breakthrough. I'm talking about as a Sarkari officer who's trying to bring about this digital, reforms within our old health sector, while ensuring that this gold value data of millions and billions of Indian citizens is protected. It is not, exploited, that there are no loopholes or leakages which make this whole ambitious plan crumble down anytime. So, and of course, the last bit was about, this gives us also the access to view and analyze immense immense ways of analyzing our public health data. So right now, I'm sure that you would have heard of things like, say, the HMIS portal, the Health Management Information Portal, which is actually a very old, almost a decade-old portal, which is conceived and run by NHM, National Health Mission, where every patient's basic records are generated. So it isn't as if that the Ministry of Health and Family Welfare all along wasn't doing anything. We were generating health records, but they were not individualized. These records were generated by thousands of our ASHA workers and ANMs through door-to-door field survey. So we have something called the RCH portal, where every female who conceives is recorded, and her ANC history is also maintained, while right to the time she becomes a JSSK, Janni Shishu Suraksha Karyakram beneficiary, and gets a free delivery, is recorded. That record further also generates the record of the baby being born in that process, and the baby's immunization history is also recorded. My point of telling you all this is that we already have these huge data dumps with us for billions of Indian citizens, and this major breakthrough in running ABDM was getting MOHFW on board. It was basically convincing another set of IS officers to cough up this bulk hugely valuable data and allow us to integrate it with ABDM. But that did happen, and Rajesh Bhushan sir, Secretary MOHFW, is to be given credit for that. So we're all good to go. So again, an example of how it works. So basically, a patient seeks a teleconsultation or visits a hospital. And I'll go back to that example of that poor tribal patient in a district on the LOC in J&K, who's visited, say, a PHC and gotten a teleconsultation. We are actually giving e-Sanjeevani teleconsultations on the LOC. That's a fact. So the guy starts there. The teleconsultation generates a ABHA ID. So, and this is where I come into the 4 building blocks of ABDM. I'm sure many of you would have heard about it. But how it works is, there's a unique health ID, or the ABHA ID as we call it. There's a ID for the treating institution, be it the sub-center or the PHC or the district hospital or even a private hospital, which is called the HFR ID, or the Health Facilities Registry ID. There's something called the HPR ID, the Healthcare Professionals Registry ID, which is basically the ID for any doctor or even a paramedic who's working in a clinic, a government clinic or a private clinic. And finally, an ABHA app, or a health records app, which is actually an interface for, and wait for it, that's the main big whole deal where it all comes together, a Digi Health Locker. So that voluminous bag which your grandfather carries with all his test records and surgery records dating back 2 decades, that whole thing goes into that DigiLocker over there. So that tribal patient, he generates his ABHA ID at that sub-center or PHC where he gets a consultation. Maybe he's undertaken an NCD screening and there's something noticed and is slated for, say, some sort of heart surgery. Okay, he goes to Srinagar. He's in Kupwara, say, and he goes to Srinagar, and he goes to this Sher-e-Kashmir Institute of Medical Sciences, and they do an angiography. And they realize that he's got a blockade, and however, it's too complicated a case, and they can't treat him there. But whatever treatment or diagnosis he's received in SCIMS will also get piled up and added to that DigiLocker which he is amassing. That patient is finally referred to AIMS Delhi. The record that was being generated is accessible with the consent and approval of the patient to the doctors at AIMS, And finally, whatever treatment he gets at AIMS is also logged into that DigiLocker. So imagine traveling from one place to the other without carrying any medical records in hard copy format, and making sure they're available to any doctor whom you are talking to just at the pinch of a hand. And in essence, actually that is, I mean, you drop your biometric, you give your consent, and your DigiLocker opens up to the consultant who's treating you. So that's the ecosystem, that's the 4 building blocks on which it all rests. And so for a citizen, it will get as simple as, say, looking up verified services all around, and booking appointments and tests, and even health records without delay, in a manner which is not limited only to government hospitals. There was a presentation by the team from Pristine here, and then I'm sure we would have heard of avenues like Liberate or Practo. ABDM is designed to encompass them all. So, for instance, if you are booking an appointment through Practo, you will always have an option to adding that particular health record generation exercise to your DigiLocker. So nothing gets untraced. It is in the future going to become that all-consuming point from where each and every health service is given. We also have this, and as I said, creating your longitudinal health history, and this is where it's important. You are able to get a unified profile irrespective of which institution you are being treated at. Even a test that you are undertaking in a private pathological lab, like Lalpath or something, even that, if you are dropping your Aadhaar ID over there, that particular score will get added to your Aadhaar record. So when we talk about the ecosystem as a whole and the various stakeholders who are involved here, we've already talked about easy discoverability, ramping up of practices, ease of doing business, of course, increased footfalls, and this is where I want to talk about how I want to give this example of ABPMJY and how far we had come. J&K is actually the first state or UT in the country to have universal ABPMJY. We're very proud of it. Every citizen of J&K gets a flat 5 lakh IPD coverage, no questions asked, and not just limited to J&K, but even all across the country. So this 5 lakh wallet is usable only at tertiary care hospitals where they go for IPD procedures. What we're trying to do now here is make that wallet flexible enough to be used by smaller service providers. So for instance, we know that, diagnostics, standalone diagnostics or separate diagnostics, which are not a part of the surgery package, are sometimes not provided by the hospitals. They actually might not have a dedicated or a separate lab for it. So even if I am getting an insurance cover in a government or a private tertiary care hospital, I might just have to get some tests done in a private lab around the corner, outside the hospital, across the road. We are trying to, this is still in the pipeline, come up with the concept of e-RuPay in ABPMJY, which will enable the use of that 5 lakh wallet even at that small diagnostic center located across the road. So it's basically like, you're using a sort of digital tokens, and say if you have like tokens worth 5 lakh, you are consuming, say, tokens worth 1,000 for the test, and say 2 lakh worth tokens for the actual surgery. So and even if, say, there are some medicines which you're not getting, which you're not able to get during the surgery, or say when we are going for a follow-up and there is a requirement which is not covered anymore because the claim has been closed, you can still continue using those e-RuPay tokens at your local pharmacy, as long as your IPD record allows you to use it. So this is the an example of the vast, immense possibilities that it opens up. And obviously, when we talk about the age of UPI and all these digital transaction systems being interlinked and interoperable, of course, we're going to have much more seamless movement and portability. So the next 3 or 4 years, we're going to see immense transformation in India's access and affordability of healthcare via digital health and telemedicine revolution, which is all powered by ABDM's digital infrastructure. This is what we're all looking forward to, what we're all are very actively working hard towards, and I invite you all to become, to partner with us and become a part of this revolution. Thank you so much. Thank you.
Thank you, Mr. Choudhary, for this insightful presentation.